I'm Dr. Nikhil Choudhary from Jaipur. I'm presenting a case of IVUS guided rota-assisted multivessel PCI in a patient with high syntax score CAD. So patient is a 70-year-old gentleman. In 2013, he underwent proximal RCA and an LCX PTCA. 2018, he had restenosis for the RCA, which presented with unstable angina. All these were done at an outside center. And that time, he underwent a proximal and mid RCA PTCA with 2 DES. This time, he presented at another center with unstable angina for the last 6 months. ECG was unremarkable. Echo showed a hypokinetic RCA territory with an EF of 45%. So these angiograms were done at an outside center, showed RCA, mild ISR proximally, distally, where there were the 2 stent overlap, some ISR, and at the distal stent edge, a 95% culprit lesion. PDPLV showed mild plaquing. So this was what his left system looked like, tight stenosis at the distal left main. So this patient came to me with this CD, and looking at the distal left main, I thought there was some aneurysm at the crux or the carina. Heavily calcified and very tortuous LAD. LCX, the proximal LCX was stented previously and it was flowing well. So with this anatomy and a syntax score of 32, I offered him coronary artery bypass. Of course, such patients refuse. And maybe 10 years previously, without imaging, I would never have thought of taking up this case. But imaging probably makes our job easier. And for this case, the things which I was actually worried about were why was basically the stent in the RCA? What was the reason for his ISR? Was it an under-expanded stent? Was it neointimal hyperplasia? Secondly, because looking at the calcific LAD, was the RCA, how much calcium was there? So again, I thought I'll do imaging and then decide. For his left system, what were the challenges here were the aneurysmal distal left main, mostly a post-stenotic dilatation. Calcium notification, of course, you'll all agree that I'll have to use multiple modalities. For rotablation here, the challenge here for me was negotiating this 90-degree left main to LAD bend. And of course, lower down the very tortuous LAD. And of course, all the complications which you associate with rota, I was expecting here. So started with the RCA, used a JR followed by an XBA and did imaging. Imaging here showed in the mid RCA an MLA of 1.8. Distal stent, there was a fibrocalcific lesion. Not much calcium in the RCA, maybe 180-degree or 90-degree calcium, and some under-expanded stent. So did an XBRCA and with a cutting balloon and non-compliant balloon with single stent, got a good result. And with fairly acceptable MSA of 7.3. And you can appreciate 3 layers of stents, but expanded then very well. So then thought of taking up at a later date, but I was comfortable doing it in the same setting. So used an ABU 3.5, and this was the images at my center. And really ugly looking aneurysmal lesion. And so I wired it and did parallel wiring with the So I then did an IVUS, but here the IVUS did not cross the proximal LAD lesion. Anyway, did a run. So what the run showed was at the proximal LAD site where the IVUS not crossing, there was a calcium spur with a 180 to 270 degree of calcium. And so the LAD ostium again calcified. And this is the distal LMCA where there was only 180 degree or 90 to 180 degree of calcium with a good lumen of around at least 2 mm and a clean looking left main ostium. So with this imaging, I started with rotablation, parked a 1.5 mm burr and crossed the distal left main burr, distal left main to LAD at 1,60,000 RPM. And beyond that, my burr was not negotiating, so what I did was change the view, increase the speed, And after that, I was able to negotiate into the mid-LED. And this was the IVUS run, and I'll just summarize here. So then after doing this, after Rota, I could do an IVUS again, and there was a 2.2 MLA. Rota cuts you can well appreciate, where at the point where I was earlier not able to negotiate, I got good result with Rota. There was still a 270 degree of arc and a calcium nodule in the mid-LED, which I had to deal. So I did a cutting balloon, used a 310 angiosculpt in the mid-LED and a 3.5 angiosculpt in the left main. And this was the result after pre-dilatation. Lot of dissection. So here again, I was afraid whether I'll be able to put a stent across or not. But thankfully, synergy crossed successfully. 2.7538 in the distal to mid-LED and 3.538 in the left main to LED. So did a pot followed by some post-dilatation all around. And this was the IVUS after that. So you can see where initially at the first septal where I was not able to negotiate because of the Rota and the cutting balloon, I was able to get good lumen area. This is the calcium area where again I was not very happy. Thought I'll do OP and NC here. And then this was the LED ostium 9.7 and the left main distal where the MLA was 8.3. Then dilated the mid-LED portion with an OP and NC 3.0 at 40 atmosphere. And did an IVUS again. And so here I got a MSA of 6. Didn't go beyond that. Didn't use a 3.5 balloon because in fear of rupturing. And I think in nodular calcium, you all have to accept maybe a suboptimal result. This was the final result which I achieved. So learning points here for me were always image before and after rotablation and after every step. Choose the burr size and speed wisely, and of course, a lot of imaging and prepare the bed properly before you put in the stent. And a lot of times use a lot of calcium modification tools, whichever are there at your disposal. Thank you, everyone.
What was the ejection fraction?
It's 45%.
So that's why you didn't think of using any hemodynamic support device.
Yeah.
Such a complex and that left main to LED bend was very nasty. A perfect recipe for a possible problem.
I agree. I was thinking of all possible complications that could happen: stuck burr, perforation. But I guess if you do each step, you take a stepwise approach, you'll be able to do the job most of the times.